can tell that all participants were great and that I learned a lot from you. So, as Valentina said, I will talk to you about titan, a titan among genes. First of all, I would like to inform you what are titans. Actually, there are 3 levels of Greek deities. The first level of Greek deities are actually formed from chaos, and then they produced titans, and titans were Cronus and Rhea, as you can see here. Cronus and Rhea, and they were father of Zeus, who actually formed the 3rd level of Greek deities, which are actually Olympians, which we know. So titans are even more important and greater than Olympian gods that we know. And now I will talk to you about neuromuscular diseases, actually about muscular dystrophies, because I work for almost 10 years at the Department for Neuromuscular Diseases. And here I show different types of muscular dystrophies, starting with congenital muscular dystrophies that appear from birth. And then the next type of muscular dystrophy that appear in childhood are dystrophinopathies, Duchenne and Becker muscular dystrophy. Then we have limb-girdle muscular dystrophy, Emery-Dreifuss, distal myopathies, facioscapulohumeral muscular dystrophy, myotonic dystrophy type 1 and 2, and oculopharyngeal muscular dystrophy that appears at the late age, after the age of 50. All of these diseases are actually rare diseases, and the prevalence is approximately less than 1 per 100,000 inhabitants from some of them, to up to 10 per 100,000 inhabitants. So all of them are rare diseases, but if we take into account all of these disorders, then the overall prevalence is about 20 per 100,000, which means about 170,000 people in Europe and approximately 30,000 people in Russia. So it is a great number of patients. There is one useful clinical rule, how to recognize myopathy and how to differentiate myopathy from neuropathy. First of all, when we see patients with proximal muscle weakness, we usually think about myopathy. And on the other hand, when we see distal muscle weakness, it is neuropathy. It's a rule that we use commonly in neurology. So let's look at these patients with proximal myopathy. Can you start the video? I can. Press on the I'm sorry. Press, it was working. We have a technical problem because we see this here and not on the big screen. Uh-oh. I have video here. So can you present this? No, first this one. Start. So we will do like this. We here see a patient with proximal muscle weakness and waddling gait. And now the next is this. He also have problems to rise from squatting position, which we call Gower's maneuver. And finally, if we look at his legs, we see wasting of proximal muscles and pseudo-hypertrophy of distal muscles of calves. So if we have waddling gait, Gower's maneuver, and calves pseudo-hypertrophy, it is very easy to make diagnosis of dystrophinopathy, which is the most common form of muscular dystrophy in childhood. As I already said, this is useful clinical rule, but each rule has exceptions. So we should look at the next patient. So as you can see, this patient has different type of walk, which we call pyronal walk or steppage gait, because of the weakness of distal muscles. He also has this phenomenon, which we called active hand grip myotonia. And he also has percussion myotonia. So in this patient we have pyronal gait, active myotonia and percussion myotonia. So it is easy to make diagnosis of myotonic dystrophy type 1, which is actually distal myopathy, and the most common form of muscular dystrophy in adulthood. There is also another very important clinical rule that means that usually patient who has proximal phenotype have mutation of some proteins that are coded by genes of sarcolemma. So you can see here, for example, that dystrophin is here, very close to the sarcolemma, sarcoglycan or laminin, dystroglycan or something. So mutations in these genes are causing proximal myopathy. On the other hand, mutations in the proteins of sarcomera usually cause distal phenotype. So if we have mutation in actin or myosin, we usually have distal myopathy. And now I will show you several other patients. For example, this patient is 23-year-old, and as you can see, he has proximal weakness with waddling gait, but also he has steppage gait. Another is this patient at the age of 33. She has also proximal weakness with waddling gait and pyronal weakness. Another patient with similar phenotype is this. She's rising with difficulties from sitting position, and she has this pyronal gait and waddling gait. And the last one from this group with the same phenotype is this patient with waddling gait and distal pyronal weakness, but which is, as you can see, asymmetrical. The left foot is more affected. So when we see all these patients, we were a little bit confused. What is the diagnosis of this disease? And we were thinking about diseases with both proximal and distal phenotype. And There is a huge list of these diseases. You probably know how it looks when you're searching the literature. As I saw from your presentation, a lot of differential diagnoses. There is a group of distal myopathies that are typical distal myopathies. Then we have atypical distal myopathies. Then we have some distal myopathies which also have affection of other organs, and some rare metabolic myopathies that also could be distal. It is more than 100 different disorders. But how we can make a diagnosis? First of all, we have typical clinical picture. So we look if patient have distal or proximal weakness and which group of muscle is the most affected. After this, we usually do additional investigations, which means CK level, creatine kinase level, is usually increased in different forms of myopathies. Then we do electromyography to see if myopathy is present and also to see if it is associated with neuropathy. And finally, MRI could be useful to see which muscles are the most affected, because clinically we cannot see affection of some muscles. After this, we usually do biopsy, and after biopsy, DNA analysis. But now DNA analysis has several levels. In some diseases, we do the analysis for specific mutation. For example, in myotonic dystrophy type 1, we are looking for CTG expansion in DMPK gene. In some other diseases, such as dystrophinopathy, Duchenne and Becker, we have to analyze the whole gene to see if they have a deletion or some missense mutation anywhere in the gene. But for example, if we have list of myofibrillar myopathies, there are many myofibrillar myopathies, so then we do gene panel. And if gene panel is negative, we go to the whole exome sequencing, and sometimes we even do whole genome sequencing, because some diseases can be produced by mutation in introns that cannot be seen by whole exome sequencing. There is some changes in this approach to the diagnosis of myopathy. The last guidelines from the American Academy of Neurology that was reported several years ago actually showed us that genetic analysis improved, and they are now cheaper than before. So before biopsy, we should do genetic analysis. And only if genetic analysis is inconclusive, then we do biopsy, because biopsy is invasive procedure. And let's summarize the phenotype of our patient. We actually see 14 patients with the same phenotype that have distal muscle weakness, which fast progressed to the proximal muscles. It was a little bit asymmetric. Legs were affected more than arms, but some of them, for example, half of this patient had scapular winging. And also, we noticed that echocardiography was normal in all of these patients. Cardiomyopathy was present only in one patient, and it was dilated cardiomyopathy. And on the other hand, respiratory function was normal in all of these patients. So they have pretty similar phenotype, and we were sure this is the same disease. When we performed a muscle MRI analysis, as you can see here, these are distal muscles and these are proximal muscles. And we usually can see different changes in muscles, like muscle fibrosis and fatty infiltration here. So as you can see, all of this patient has affection of this muscle. It is tibialis anterior muscle. And some of them also had affection of a posterior compartment or lower legs. It is gastrocnemius and soleus muscle, which was asymmetrically affected, as you can see here. After affection of the distal muscles, we can notice affection of the proximal muscles, usually first the posterior compartment of upper legs, which is also asymmetrical to a certain degree. And after the long duration of disease, we also can observe affection of the anterior compartment of upper legs. When we performed muscle biopsy, we actually see variation in fiber size. You see very large fibers and small fibers, and a lot of internal nuclei. And also, in some patients, after the long course of disease, you can see fibrotic and fat tissue infiltration. Table C is actually a patient who had only 14 years, and he has only mild symptoms of this disease, and on the biopsy you can see just very insignificant variation in fiber size and some internal nucleus. So it is very mild presentation on biopsy also. And what to do next? We have a clinical picture, we have additional clinical investigations, and we have MRI and biopsy, and what to do next. We were that lucky that we were included in the MAIA-STAC project. The aim of this project was to analyze whole exome sequencing in patients with unexplained limb-girdle muscle weakness, and the aim was to improve diagnosis of limb-girdle muscular dystrophies, to increase awareness of neuromuscular disorders, and to introduce next-generation sequencing in health system. So more than 50 centers in Europe were included, and more than 1,000 patients. And this was guided by the Newcastle University John Walton Muscular Dystrophy Center and Harvard University Massachusetts Institute of Technology. Our clinic sent 94 patients who fulfilled the inclusion criteria of 1,000 patients. 73 of them had limb-girdle muscular dystrophy phenotype. Others have limb-girdle muscular weakness but not dystrophy. And 62 of these patients were positive by analysis of only 169 genes that are associated with neuromuscular diseases. And the results were a little bit surprising, because in every country in the world, the most common limb-girdle muscular dystrophy is actually calpainopathy. But in Serbia, it was the second most common. The most common was actually tendinopathy. And we were surprised that approximately 1/5 of our patients with limb-girdle muscular dystrophy actually have tendinopathy. When we take it into account patients with primary distal phenotype, then we can conclude that 3/4 of our patients from Serbia with distal phenotype actually had tendinopathy. Here I will show you what is the function of the titin. You probably know the structure of the sarcomere. We have Z disc here, we have M line here, we have actin, we have myosin, and we have titin, whose role is to fix myosin to Z disc. And it is very elastic, so because it should be stretched during the muscle contraction and muscle relaxation. Titin is actually the largest protein in our organism, and it had this N terminal, which is the part that is coded part of the protein associated with Z disc, and it had C terminal, which is associated with M line. All mutations that are associated with muscle diseases and cardiomyopathy to now are usually located in this part of titin, which is a part that codes for M line, A band, and sometimes I band. And these last 6 exons are called MEX 1, 2, 3, 5, 4, and 6, because other exons, and this is very large gene with 363 exons, are not so important for human diseases as we know so far. And when we performed this analysis of next generation sequences, we actually found mutation in the M line of titin, which is missense mutation that causes early termination of transcription of the titin. So the titin that is produced in this patient is very short and non-functional. And all of these patients also had another mutation in M line, A band, or I band. So this was clearly autosomal recessive disease. And this fits with the data from the patients that nobody in their families, their parents, didn't have this disease. Another interesting thing, is that we observed one haplotype box around this gene that was the same in all our patients. And this means that there is a founder effect. According to the microsatellite that we analyzed close to this gene, we found that the mutational age of this titin mutation is approximately 40 generations, which means approximately 800 years. So this mutation appeared in Serbia in medieval century when actually the first Serbian country of Raška was formed, and all of these patients that are reported here are from Serbia, Bosnia, Croatia, and Montenegro. The next step was to prove that this mutation that we found is actually mutation, not a variant. And there are several steps how to do this. First of all, this was extremely rare variant in the exact data set. So we observed only 2 heterozygous carriers in the world among 60,000 individuals that were tested. Another important thing is that we didn't observe this variation in 100 controls of healthy Serbian individuals. And we also performed family segregation analysis that showed that all relatives who were heterozygous carriers of those variants were actually asymptomatic. So it was clear this is autosomal recessive disease. The next step to prove the pathogenicity of some new variant is actually to create knockout mice with this mutation, which we didn't do because it's very expensive. And another thing is to analyze the level of titin RNA and titin protein in muscle cells of patients, which is also complicated and invasive for patients, so we didn't do this analysis. And after all, we published this paper in the European Journal of Human Genetics, and the conclusion is actually that we described the new phenotype, which was observed only by clinical observation and confirmed by genetic analysis. And now we know in Serbia, when we see patients with distal myopathy, we first do analysis for titin. If we don't know this, we cannot start to cure our patients because gene therapy is now ongoing. There are some clinical trials with gene therapy on muscular dystrophies, for example, in the United States. Before, if we don't know diagnosis, the exact genetic diagnosis, we cannot even think about gene therapy. And the important thing is, in this story, we included neurologists, pathologists, radiologists, geneticists. It is a teamwork, which is very important, which you already know from this tournament. Thank you very much for your attention. If you have some questions, I'm here.
Hello. Can you please return to the second patient with distal muscle dystrophy and his symptom when he was holding his
Yes.
hands like this? Can you please just explain
video
again what is the sign of this? Where should we look?
Okay. You think this?
Yeah.
It is active hand grip myotonia that is typical for myotonic dystrophy type 1, 2, and some non-dystrophic myotonias, which means slow the contraction of muscles after hand grip because they have actually changes in the chlorine channel in the membrane. So the contraction and repolarization is very slow. You see, like this. Another sign is percussion myotonia, which is the same thing. But sometimes when active hand grip myotonia is negative, then we do this, and this is usually positive. It means slow the contraction of the abductor of the thumb after percussion on the tenor. And this also can be seen in electromyoneurography. If you do this, you hear a specific sign and the specific voice of the bombarder.
Thank you very much.
Welcome. Okay, if you have no another questions, then that's all, and you can ask me later if you have something. Thank you.